tonight.
My mother was diagnosed in her early 40s, so that put me in a high-risk category.
So we sent her down for some imaging. She had a mass that looked suspicious,
which led to a biopsy.
At that point, the cancer was detected.
An ABC 27 special presentation.
I just thought I had a sore spot. It was about the size of a pea from bumping myself or something. They did the biopsy, and it came back as stage 2 breast cancer.
Penn State Hershey Breast Center presents Hope and Courage, a tribute to breast health, brought to you by Penn State Milton S. Hershey Medical Center.
Good evening, I'm Deborah Pinkerton. For the last 30 years, October has been known as Breast Cancer Awareness Month worldwide. From football games to buildings with pink lights, you can see pink is everywhere. The push is to save lives by early detection. In 2015, the American Cancer Society estimates that more than 232,000 women will be diagnosed with invasive breast cancer, and nearly 40,000 women will die. For women, breast cancer is the second leading cause of death from cancer. Although the numbers are still high, there are now more than 2.8 million breast cancer survivors in the United States. Who is considered high risk and what advances have been made to help catch breast cancer earlier? Well, you will find out tonight. If you have questions, specialists are here to answer them. Carrie Perry is here to tell you how.
Thanks, Deborah. Specialists from Penn State Hershey Breast Center are in the ABC 27 call center to answer your questions until 8 o'clock. Call the number on the bottom of your screen, or you can email your questions during the show to questions@abc27.com. Dr. Polishak will answer your emails throughout tonight's show, and all calls and emails are confidential. I'll be back later in the show to share some of those questions with you. Back to you, Deborah.
And thanks, Carrie. Our first story of hope and courage is about a Cumberland County woman who had a family history of breast cancer. She knew she had a greater chance of developing breast cancer, but at age 33, Erin Monroe never expected to be diagnosed with it.
Here we go. Go ahead, buddy.
2-year-old Jack Monroe takes off. The little bundle of energy enjoys the simple things in life.
Hold on tight.
Good job.
Jack's parents, Aaron and John, enjoy the simpler life too. They're ready for some normalcy. Over the past 7 months, they've experienced almost every emotion possible. It all began in March.
I was referred to the breast center at Hershey Medical Center because I was considered high risk.
Erin's mother was diagnosed with breast cancer in her early 40s.
She passed away when I was 16 in 1998. She was wonderful, but she fought as best she could and unfortunately didn't make it.
Erin knew it was important to meet with Annie Arguin, the nurse practitioner who runs the high-risk clinic at the breast center.
Her initial appointment with me, we just discussed her family history. I discussed how I would be following her. And at the end of my appointment, I always do an exam on the women. And when I did an exam on Erin, I was able to palpate a mass in her right breast.
Terrifying, I think, would be probably the initial reaction, just with family history.
So we sent her down for some imaging. We had a mammography and an ultrasound that was completed, and she had a mass that looked suspicious to us and led to her having a biopsy.
I kept telling myself, like, I'm only 33. I have a 2-year-old at home. This isn't happening. But it was.
It just knocks you down, you know. It was hard to even process it, and this, of all things, was the worst because of her mom. And I knew how she would react.
Pathology reports confirmed Erin and John's worst fear.
It confirmed a breast cancer, and then she had a type of breast cancer that's common in younger women, which is called triple-negative breast cancer. So her tumor was not fed by estrogen.
They also biopsied at the same time a lymph node, which they had also seen, which was slightly abnormal, which also was noted to have cancer in that lymph node as well.
and I flat out asked them if it was a treatable type and what they thought the odds were, and they were very honest, and they said, this is absolutely treatable. We're gonna do what we need to do, and it was never ever if, it was when you get better.
The surgery was important, but really the life-saving part of her treatment was going to be chemotherapy, because triple-negative breast cancers are aggressive, but they also respond really well to chemotherapy. So chemotherapy, when given in this situation, often double the chance of cure.
Okay, we know what it is, we know what we're gonna do, we know how to move forward now, let's go.
Within 3 weeks of being diagnosed, Erin started chemotherapy.
So every cycle of chemotherapy that Erin had, we were able to measure her tumor and confirm that it was getting smaller with each treatment.
Knowing how difficult the next cycles were going to be to get through all of the chemotherapy, but knowing that it was doing what it needed to do, I mean, that's all we needed to hear.
An MRI confirmed the chemotherapy was doing its job.
This is the MRI before chemotherapy. On this MRI, you see that bright white area around that black center. That black center is the biopsy clip. That bright white area is the cancer. After chemotherapy, you see complete response to the chemotherapy, no residual bright white areas of enhancement.
Surgery was next. Erin had a bilateral mastectomy and reconstruction.
When we went to surgery after her chemotherapy, on final pathology, they showed complete response to the chemotherapy, and there was no residual tumor in the breast, as well as we removed the lymph node that had been biopsied and 3 other lymph nodes, and all the lymph nodes were negative for any cancer in those lymph nodes.
We don't use the cured word, but she goes, this is the best possible outcome. She goes, you responded to the treatments the best way you could have. So it was one of those like best days of your life type thing.
So it's a huge, huge weight lifted. These are the happy tears.
Now Erin and John can put this behind them and look forward to happy times with Jack.
Mommy, I go fishing for you.
Okay. I'm able to pick him up and give him hugs now and play together. And good job.
Jeez.
Catch up on a lot of the things that we didn't get to do this summer together that we had envisioned.
I can't put into words what she's been through. She's just the absolute strongest person that I know. She's kind of my hero in everything.
Erin encourages women to get mammograms. She says no matter what your fear is, the mammogram can save your life. And joining us tonight is breast surgeon Christine Witters. Thank you for being here. Erin was only 33 when she was diagnosed. How common is it for breast cancer to be found at such an early age?
The National Institute of Health reports that at age 30, a woman's risk of getting breast cancer is only 0.44%, or that's 1 in 227. By age 40, that risk does go up to about 1.4%, about 1 in 68. Although it is uncommon for women her age to get breast cancer, we still recommend that starting at age 20, a woman get an annual breast exam, as well as get risk assessment and the appropriate screening.
Now, Erin was enrolled in the high-risk clinic. How do you become a patient there?
So since March 2014, we've seen about 400 women in the high-risk clinic at the Penn State Hershey Breast Center. Majority of them are referred by their GYN, primary care physician, or by radiology. If they don't have a referral, we have a set of screening questions that we ask them to see whether they meet criteria for our high-risk clinic. Some of those questions are, do they have a family history of breast cancer in a first or second degree relative like their mother, sister, aunt, grandmother, or daughter? Also, we ask about male breast cancer or cancer at a young age. Additionally, we ask, do they have history of prior biopsies or a family history of a genetic mutation or radiation to the chest at a young age?
And how are these high-risk patients followed?
We try to tailor their treatment care based on their risk assessment. That may include things like mammogram, MRIs, whole breast ultrasound, as well as biannual breast exams. We also do offer chemo prevention, and in the setting of gene-related breast cancer risk, we also offer risk-reducing surgery.
Okay, and as far as in Erin's case, she did receive chemotherapy because it works well with the triple negative breast cancer. What are other common types of breast cancer and how are they treated?
The most common types of breast cancer are lobular and ductal. They occur in the glandular tissue of the breast. Current treatment models have really moved away from a one-size-fits-all model to tailoring specific treatment plans based on that patient's cancer. We test all cancers for estrogen, progesterone receptors, as well as HER2/neu receptors. Those are all targets that we can use targeted medication. Additionally, we test in early breast cancers. We do oncotype testing, which is a 21 gene panel done on the patient's tumor to determine if this is a high chance of it coming back in their breast or elsewhere. So we really try to tailor it specific to their tumor.
Very personalized. Dr. Witters, thank you so much for being here this evening. And why don't we check in with Carrie Perry to see how everything is going in the ABC 27 call center. Carrie?
Well, it's really going well, Deborah. The phone lines are busy. And if you want, you can call in 717-346-3333 here to answer your viewer questions tonight. The co-director of the Hershey Breast Center is Dr. Rena Cass. We have our first question for you tonight. Great. I've tested positive for the BRCA gene, but don't have breast cancer. I'm thinking of getting my breast removed, but I'd like to know, is there still a chance I can get breast cancer? If yes, how would it be detected if I can't have a mammogram?
Great question. So let me first say that when we perform a prophylactic mastectomy, similar to what Angelina Jolie had, we markedly reduce the incidence of breast cancer by about 94%. But it's not 100%, and that's because there are a few breast cells that are left behind along the skin flap. So we have to follow the patient, and that's why we perform clinical exams on the patients that we've operated on. If there's any concern down the road that something has changed in that breast that we've reconstructed, or even if we haven't reconstructed, then we might do some additional imaging, which may include a mammogram or an MRI or other forms of imaging.
Excellent. Thank you so much, Doctor. If the phone lines are busy, you can email your questions to questions@abc27.com. Back to you, Deborah.
Thanks, Carrie. Later in the show, do you have dense breasts? Are you more at risk for breast cancer? We'll show you the latest technology available when screening for breast cancer. And up next, you'll meet a woman who felt a lump during a self-breast exam and knew something wasn't quite right. You'll see the journey she took to decrease her chances of breast cancer coming back. Stay with us. We will be right back.
You're watching Hope and Courage, a tribute to breast health on ABC 27, brought to you by Penn State Milton S. Hershey Medical Center.
Welcome back. Our second story of hope and courage takes us to Lebanon County. No one is ever ready to hear they have breast cancer. Millie Blount had a hard time believing the diagnosis.
Are you coming? 53-year-old Millie Blount and her husband Steve spend this sunny day four-wheeling, a favorite pastime of theirs.
It's just because of where we live. It's just part of us. And our grandchildren really like to come and ride four-wheelers.
Millie appreciates these happy moments because there was a time not so long ago when she wasn't quite sure which way her life was headed.
It just showed up as a sore spot, a tender spot on my breast. And, you know, I kept on saying to my husband, you know, this really hurts here. And I had him feel it.
My daughter and me, we would both, you know, sort of encourage her, well, maybe need to get it checked.
So I went a little longer and they pushed me to go get it checked.
When Millie presented for her mammogram, she had a palpable mass. And by palpable mass means she could feel something in her breast.
They did the mammogram, they came out and they said, we need to do an ultrasound.
An ultrasound led to a biopsy.
In your mind, you're wondering what's going on, that it has to be continued to be investigated.
They did the biopsy. And it came back as stage 2 breast cancer.
You never forget getting that phone call that says, Mr. Blount, I just want to let you know that your wife has cancer. Sort of as a bombshell.
The metallic BB on the skin surface marks the area that she could feel. And this area under the skin, this brighter, whiter area, is the area of the tumor. So you can see it's a little bit more dense than the adjacent breast tissue.
You hear all the horrible things of cancer and what it does and the results. And what does that put in front of us?
Most women, depending on the size of their tumor, have the option to keep their breast and have a lumpectomy, which means just removing their cancer, or have a bilateral mastectomy, or even a unilateral mastectomy.
We decided, okay, this is a no-brainer. Let's just lessen my chances of breast cancer coming back and do a bilateral mastectomy. It was not an easy decision to make because, as sad as to say, your breasts are a big part of who you are.
Along with that decision, Millie chose to have reconstruction.
If they're opting to have reconstruction, it's a surgery that we coordinate with our plastic surgeons, so that way they're in the operating room at the same time we are. That way when we remove the breast, they're able to start the immediate reconstruction in that same surgery.
The first time I met Millie, we discussed about the options, and we mostly entertained doing an abdominally based free flap for reconstruction of both her breasts.
You know, they talked about hours of surgery. You know, could be 18 hours of surgery.
A free flap is basically where we remove the tissue from the abdomen, much like in a tummy tuck, but along with its artery and vein. And in her case, we were able to remove that tissue without actually removing any of her muscle underneath, so it completely preserved her muscle function of her belly. That tissue was then transferred from the abdomen into her chest wound after the breast surgeon had removed both breasts, and then we rehooked up the blood supply and molded that tissue into a breast for her.
The doctor came down to see me. The doctor was confident that it was a good surgery.
It was a 14-hour surgery. I don't remember much from leaving Steve behind and waking up the next day in the ICU.
The first step on her road to recovery.
I have not left to define who I am. I am going to come out a winner, and that is because of my faith and my family and friends.
She's doing good. She's recovered fully, able to resume all of her normal activities, being able to ride on four-wheelers, have fun with the grandkids.
Every day I look at my mirror and I have this Bible verse. I can do all things through him who strengthens me. And I believe that gives me the strength to get through my day.
Millie is doing remarkable. She hopes her story gives inspiration to women who are diagnosed with breast cancer and have to make those tough choices. Joining us right now is plastic surgeon Dr. Kathy Henry. Thanks for being here. What types of reconstruction are most common?
Breast reconstruction generally falls into two major categories, using either an implant or the patient's own tissue to recreate a breast mound after the mastectomy is completed. The most common source of the most common variants of the abdominal tissue, which is the most common source for the reconstruction, are a muscle-sparing tram or a DIEP flap. Any variation involves taking the skin and fat from the lower abdomen, transferring it up to the chest wall, and hooking up the blood vessels under a microscope.
And what factors are considered in choosing which type of reconstruction you should have?
One factor is the patient's desired size after the reconstruction is completed. We also consider whether or not any radiation therapy is going to be needed to treat their cancer. We also, if someone wants to pursue the free flap based surgery, we'll often get a CT scan of the abdomen just to make sure that their anatomy is appropriate.
And after reconstruction, does a woman need a mammogram?
No, on the reconstructed breast, whether it be either implant or using her own tissue, a mammogram is not necessary. We still recommend that they perform self-exams and complete any surveillance that's been recommended by their oncologist or breast surgeon.
Okay, Dr. Henry, thank you so much for joining us this evening. Let's go back to the ABC 27 call center. Carrie, how's it going over there?
Deborah, the phone lines are really lighting up. A lot of great questions. If you have questions too, just dial 717-346-3333. If you can't get in on the phone lines, that's okay. You can email your questions during the show to questions@abc27.com. And while we still have Dr. Cass here, we have some more questions. The next one is, I'm having a lumpectomy on my left breast. I'm told I don't need chemo, but will need radiation and hormone therapy. I've heard radiation to the left breast can damage the heart. Is this true?
So many women actually ask that question. And I would say this, that decades ago, radiation treatment to the breast or the chest wall was associated with down the road heart dysfunction. Okay, elevated levels of heart dysfunction. But now, with our image-guided treatment planning and conformal treatment planning, we can now localize where the heart is so we know how to avoid it.
That's excellent. I've got another question for you. My aunt lives with me and is getting chemo right now. I take her to treatments, support groups, and try to be as caring and supportive as I can. It's starting to wear on me. Do you have any options for groups of those caring for breast cancer patients? Big question.
Wow, what a great niece. I really applaud her for everything she's doing for her aunt. Yes, you know what? We have to care for not only the patient, but the caregivers. And at the Penn State Cancer Institute, we have a support group for caregivers on the third Thursday of every month at 6 o'clock. You don't need to make a reservation. You just need to show up. It's on the 7th floor of the main hospital. You can always call the breast center and we can give you more information.
Thanks again so much, Dr. Koss, for being here and answering the questions tonight. We also want to thank all the specialists who are here with the phone lines open. For now, we're going to take it back to you, Deborah.
Thanks, Carrie. Dr. Susan Cheddar, co-director of the Breast Center, now joins us. Thanks for being here. Are women with dense breasts more at risk for developing breast cancer?
So most of the focus on breast density has been on how that dense breast tissue masks a developing cancer in the breast. But there's also very good evidence that women with high breast density are more susceptible to the development of breast cancer.
And what advances have been made in mammograms to detect breast cancer earlier?
So moving to digital mammography was a huge improvement over the old screen film mammography. And now there's also excellent evidence that 3D mammography will be even more sensitive. An article that was printed in JAMA and just last year, of 450,000 women showed that the 3D technique was not only more sensitive in detecting cancer, but there were also fewer callbacks after screening.
And what other technology advances are there at the breast center?
So one of the other technologies that we're currently applying to women who are of higher risk with high breast density is screening whole breast ultrasound. And there's also very good evidence that in this population, higher risk women with high breast density, there's a 28% increase in the number of cancers that can be identified. So we're very excited to have added that at the breast center.
And are you aware of any current research or advances in testing for breast cancer?
Well, the current advances primarily address screening modalities, but researchers are also looking at biomarkers. And these biomarkers are proteins that circulate in our bloodstream. They may be identified in your blood and perhaps even with a cheek swab. So we're hoping someday we may be able to make this diagnosis and the diagnosis of other diseases in a more comfortable and accurate fashion.
And what makes the Hershey Breast Center really stand out for patients?
I would say it's our multidisciplinary team. From the time a woman walks through our doors, there is a team there that will address any of her breast care needs. So from screening to interacting with a surgeon or an oncologist or even a risk assessment, there is a group of people who are under the same roof, in constant communication, and able to expedite care.
And especially there in Erin's case, I know she was telling me within, say, a 2-hour period, she had her mammogram, she had her ultrasound, and she had her biopsy, all under one roof.
It's one of the things we're most proud of. If a woman is told she needs a biopsy, the last thing she wants to do is pack up, go home, and come back in a few days or a week or 2 weeks. So we try to accommodate everyone same day.
And I know this is something you want to talk about. This week, the American Cancer Society updated their guidelines and now recommend annual breast cancer screening at age 45 instead of 40. What are your
Yes.
thoughts?
So our breast care group actually recommends the screening start at 40. We do understand the American Cancer Society recommendations. If you read the article that was published in JAMA in which these guidelines were put forth, they cite evidence that proves that early cancer detection, mammography starting at age 40, will detect more cancers and save more lives. If you are 40 to 44 years old and you would like a mammogram, the major question is, can you tolerate the uncertainty of a false positive? It's either tolerating the false positive or not being screened for cancer. And we feel that most women would choose to be proactive about their health and be screened.
Okay, Dr. Susan Cheddar, thank you so much for being here this evening. And we also want to thank you, our viewers, for sharing your stories and sending in your questions. If you would like more information or you would like to schedule a mammogram at the Penn State Hershey Breast Center, call 1-800-243-1455 or visit online at pennstatehershey.org/breast.